Thank you very much. Appreciate being here. So we're going to talk a little bit about spot stenting versus the full metal jacket. These are my disclosures. Obviously, we talk a lot about the SFA twisting and turning, compressing, and a lot of the early generation nitinol stents were straight pipes, and stent fractures were very common, led to loss of patency. The newer generation stents tend to try to address these forces, and you can see this is your typical SFA and popliteal segment with the forces that are being applied. So any long scaffold would need to be able to address this type of motion, which is obviously a challenge. A lot of times after you put that metal in there too, the standard vasomotor function gets impacted because of this metal. And you can see the difference between the earlier generation stents and the newer generation stents in terms of flexibility. But despite this, still long scaffolds have their limitations. And when you place these full metal jackets, it impedes the natural movement. You have a lot of high metal burden, high radial force, and inflammation. And this also limits future options for treatment as well, too, including bypass. And when we have this chronic outward force, you get this aggressive neointimal hyperplasia. Especially, we tend to oversize stents. With the newer biomimetic stents, we try to size 1 to 1.1. But there are different sized vessels, and so when you place larger stents in smaller vessels, there's more force that's exerted and potentially higher risk for restenosis as well. If we take a look at Supera and within the Superb study, when placed nominally, the Supera stent has excellent freedom from TLR, even going out to 3 years. But if you take a look at patients with severe elongation, so if you run on the stent, that patency rate goes way down. With compression, it's less so, but still potentially a problem. And then the longer the stent length as well, too, this will also potentially impact as well. But a Supera placed perfectly will have very excellent patency rates, but it's very hard to achieve given the difficulties in delivery. So what about dissections? This is also something that we tend to deal with as well, too, not always resolved with prolonged inflations. And then, unfortunately, may impact patency as well, too. And if you look at all the DCB trials, in this section, we're talking a lot about DCBs as well, you can see that 84% of the cases that involve PTA, either POB or DCB, had some type of dissection within these registries as well. So, and then in almost half of these cases, you had severe dissection as well, too. So there's still a need for some type of scaffolding, whether or not stents or alternative technologies within the drug-coated era. So, they asked me to talk a little bit about spot scaffolding or spot stenting. And, when you see these dissections, the patients that have grade C or more have higher rates of TLR, in comparison to the patients that don't have that. So the concept that you could maybe use some type of microstent with low radial force could potentially improve patency as well. And that's where the TAC implant came about. And if you compare the TAC implant, which is a very short nitinol scaffold with very low outward radial force, in comparison to a traditional stent, you can see there's a lot less inflammation within this rabbit model. The length of this stent is only about 8 millimeters, and it's biomimetic and also will adjust to the size of the vessel because of that very low outward radial force. So you essentially have a large size range between 4 to 8 millimeters with the newer generation above the knee stent. So if we look at dissections, for example, you've done a good vessel prep, and then you have a long length dissection to place a long Supera or other type of stent, you'd be able to use 70% less metal to treat the same dissection, potentially using the scaffolding system using TAC. And then it also, at the same time, it also preserves treatment options while giving you very comparable patency to the previous stent studies that have been done in the past. We look at the data as well, too, briefly. You can see within the TOBA 2 and also TOBA 3 trials, very strong patency rates of freedom from CDTLR. TOBA 3, I think, is worth highlighting, though. That was combined with Impact Admiral drug-coated balloon, and it had drug-eluting stent-like results at 12 months. So you can see a 95% patency rate and freedom from CDTLR at 98%. And if we look at these patency rates and Kaplan-Meier curves, you can see going out to 24 months, 92% freedom from CDTLR, and really impressive patency rates as well, too. And you can see that in the long length population, whenever you have a longer length lesion, of course the patency rates and freedom from CDTLR is not as good, but you can see that the patency rates were quite excellent. That freedom from CDTLR was 83% at 24 months. So this is a quick example. This is a patient with a flush osteocclusion. Of course, in this kind of case, we would tend to go retrograde. I came from the foot and crossed relatively easily through the cap. And then you can see here, post laser and balloon, I have a fairly extensive dissection that you can see. So what are my options here? I could put a long link supera here, or I could consider an alternative. And in this particular scenario, I ended up using a long Ranger drug-coated balloon, and then ended up placing several TAC stents. And afterwards, I try to size 1-to-1 with the wire so that we don't cause any TAC migration. And afterwards, you can see that we have an excellent result. And this patient's actually done quite well. This was done about a year ago, and patient remains patent via ultrasound. This is another case worthwhile to show, because of the differences you can see with recoil. So you can see this patient has extensive plaque. We're intraluminal as we crossed from below, but as we move up, and I'm going to skip ahead here, you can see that that we end up in the subintimal plane here. So there's the reconstitution segment was in the mid SFA, and then we ended up going for a fairly long length subintimal until we re-entered. So unfortunately, I don't want to lose all of that patent SFA, so I used Pioneer with IVUS guidance to pop back into the true lumen within the mid SFA. And you can see I ended up fixing the below the knee segments as well too. I didn't show the initial pictures, but ended up having to fix the PT there as well too in the distal popliteal. And then ended up using turbo power laser with angiosculpt, and ultimately used a Alluvia scaffold for the long recoil segment in the mid to distal SFA. So that's not an area that was really appropriate, I think, to TAC, because that was a long CTO segment. Even with debulking, there was still recoil. So that's where a scaffold, I think, makes a lot of sense. But we went ahead and saw this here. So I thought I had done a good result. In one view, it looked like you had a beautiful patent segment, but you can see that we had a pressurized dissection. So that area that I had crossed subintimally, if I had taken the patient off the table as everything was great, this patient would have shut down very quickly. So this is a situation where we decided to go ahead and attack and then use a balloon afterwards to kind of squeegee out the blood that's in the intramural hematoma. So this is what it looked like afterwards. We thought we actually done a pretty good job. But then you can see very focally at the top, there is one strut of the TAC that's sticking out. So this is, again, a short recoil. And so because of this segment, I decided to put a short DES right at that top segment. And ultimately, the results look excellent. So you can see this is the final result, the combination between the TACs and also the Alluvia stent down below. And this is our runoff. And the patient did actually very well. So in summary, it's important to recognize recoil and also recognize the difference between dissected segments and obviously segments that require a long scaffold. When we talk about restenosis as well too, I think it's also important. The good thing with utilizing a spot scaffolding with TAC, you're able to re-intervene upon these things very easily. And Kalluri did an analysis from TOBA2 and found that in general, when TACs do restenose, they're much more short segments. So Tasaka 3 long CTOs, or what we're seeing these little short segment occlusions that you're easily able to pop through. And at that point, you can treat them any which way you want. And if you want to do laser and drug-coated balloon therapy after the fact, that certainly can be done, and it is easily addressed. So vessel prep, I think, is very key for these kind of things to decide. If you don't do vessel prep before you decide which way you're going to go, whether it's spot scaffolding versus stenting, then you're going to end up with very poor results. Ultimately, folks who just tend to do ballooning, they tend to have a lot more stenting in general. So I think there is a role potentially for atherectomy solutions, debulking therapies, and potentially drug-coated balloons in combination with these spot scaffolds as well. Thank you very much.